The topic for this week is mandibular injection techniques. Again, following the presentation, we will like to have some discussion about various mandibular techniques used in both pediatric, geriatric and general population. For the discussion, we have Dr. Ilavenil, Professor in Oral Maxillofacial Surgery at SRM Dental College, Ramapuram, and Dr. Sneha, Professor in Oral Maxillofacial Surgery at Savitha Dental College, Chennai.
Hello.
About the various techniques. Yes, they were all discussed during the presentation, but then I would like to get more inputs about various techniques that we use in our day-to-day practice. There are many techniques like mental nerve block, inferior alveolar nerve block, different techniques in inferior alveolar to anesthetize inferior alveolar nerve. Then you have your Gaugates, Vazirani, and the extra oral mandibular technique. In our routine practice, we give our conventional inferior alveolar nerve block. Do you prefer a direct nerve block over the other technique, which is the Fisher 1, 2, 3? If yes, why? If not, why not? We'll start with you.
I would prefer a direct nerve block because I think that gives the best access. You do not change the tissue planes multiple times, and it is pretty effective. But more than the technique differentiating between direct and indirect, the very same direct technique I feel has to be custom made to the patient that you're handling. Based on the patient's morphological characteristics, I would definitely look at those aspects. For example, in a pediatric patient, we know that the mandibular foramen is about 7 to 10 millimeters above the molars, but in a pediatric patient, it is much lower. So we will have to lower the plane of the syringe. So those are tiny things which will definitely make a difference in a patient. Also, to talk about the morphological aspects, a patient with a skeletal class 3, the mandibular foramen is much above. So we cannot go by the same. So evaluating a patient completely, including the morphological characteristics, is very important.
What about your perspective?
I would definitely prefer a direct technique. One, because it's easier to learn, easier to practice. The learning curve is very minimal. We have very few landmarks to remember to reach our target site. And I think most of the practitioners, if we ask them, it gives you good, profound anesthesia, and it's the simplest way to do it. When we look at the problems when we are looking at a conventional inferior alveolar or the Halstead's technique, the problem is it is a second injection that's needed for a long buccal, which the patient may not be usually prepared to, because he will think, "One injection kuduthittinga, one injection is given. Why are you poking me again?" That's the first problem, which is not a problem when we are doing Fisher 1, 2, 3, because we start with long buccal and then your needle is just going on and on. So he does not realize that there is a second prick. Second thing is, as ma'am mentioned, there are anatomical landmarks that we have to get into or understand to reach the foramen, and we have to understand the anatomical differences that can be there in a pediatric, adult, and different angulations of mandible, high angle, low angle cases. But there are also soft tissue landmarks where when we ask the patient to open the mouth wide, the height of injection always corresponds to the deepest point of pterygomandibular raphe, which is going to adjust to the position of the growth of the ramus of the mandible. So those landmarks and identifying the importance, correlating the importance of those landmarks to the technique that you are using becomes essential for any practitioner. And the other problem with the conventional INB is that the patient has to open his mouth. When the patient does not open his mouth, that is where we are stuck. That is where Vazirani echinocy works. But when we again look at it, when the needle is in the pterygomandibular space, which is about 2.5 ml of volume, and you're depositing 1.8 ml of solution, even if you're closest in proximity to the nerve, the chances that your block works well is good, provided we deposit adequate volume of the local anesthetic solution.
Yes, we don't actually have to go closer to
the nerve.
We just have to fill
deposit in the space,
the pterygomandibular space.
The problem that happens is most of the students, when we teach them how to do it, they deposit the local anesthetic much more anterior, and they don't understand the point that your needle has to penetrate the buccinator and then go enter the pterygomandibular space. So if you are more anterior to the buccinator when you're depositing your local anesthetic, it will never diffuse to the muscle and go. But once it reaches the space, anywhere it is, you are going to have anesthesia. But sometimes it may be spotted because the volume is inadequate and it has not reached the nerve, and there's not adequate molecules that have diffused through all layers of the nerve because just tightly away. So that is the reason why even for a beginner, IANB conventional works much better compared to any other mandibular nerve blocks.
Yeah, you're spot on. But then that leads to the next question about the volume. Usually we give 1.2 to 1.5 cc. But then is that adequate, or do you need to use more volume of local anesthetic solution in order to achieve profound anesthesia? But then, mind you, it's a technical issue. If your technique is right, then you can use whatever. But then, are you trying to overcompensate with the solution, volume of solution, because of your proper technique?
So when we are looking at an inferior alveolar nerve block and we are looking at the pterygomandibular space, we have to understand one thing, that the height of injection is above the level of occlusal plane. So we are not going too low that, we are too far away from the foramen. So anywhere we inject, we are nearly around the foramen until unless we have gone grossly anterior and gone into the parotid. Otherwise, we generally hit that area, because the first thing we have to understand is we cannot go below the alveolus level. We are always above the level of alveolus. And in that case, we maybe 8 to 10 mm is the height above the mandibular plane.
Yeah.
Even if we don't go 8 to 10 mm, even if we are 5 mm above, we are still close to the nerve.
In fact, it is said that you can err on the side of going superior. So if you go superior, by gravity, if the solution descends down also, you're anesthetizing.
the nerve.
Only thing is we cannot go much lower in an adult patient, or medial. Then you go medial to the sphenomandibular ligament, which again becomes a barrier.
So
diffusion.
Two important soft tissue landmarks. One is your buccinator, next is your ligament.
Yes.
So the volume, you neatly explained the mandibular, the anatomy and the procedure. So we'll stick to 1.2 to 1.5 ml. That is because just in case if you want to, the block is not working, you want to repeat the and that is one. And when speaking about the mandibular nerve technique, do you have anything specific for a patient with submucous fibrosis? A patient comes to you for an extraction of or any procedure with a restricted mouth opening because of fibrosis. Trismus is, I'm not bringing trismus into consideration here, about as a patient with submucous fibrosis.
Yeah, definitely the problem that we are looking at here is the restricted mouth opening. I think then we are left with only one technique, which is Vazirani.
Yes, but then what about the
tissue fibrosis? Yes. Tissue fibrosis is definitely an issue, and it is definitely a barrier for the penetration of local anesthetic. Yes, that needs to be accounted. But again, the fibrosis is perimuscular fibrosis, and it is not in the connective tissue or the myxomatous tissue that is present within the pterygomandibular space. So as long as we enter the space, it is not an issue. When we don't enter the space and we are anterior, again where the buccinator is,
we may not get the adequate diffusion.
Then we may not get diffusion, because even in a normal patient it may still diffuse, but in a fibrosis patient it does not diffuse. So we have to be more accurate when we are trying to deal with these kind of patients.
So speaking of accuracy, that is another thing which is commonly not followed. Regarding the choice of the gauge of the needle. Would you go for a thinner needle or a slightly thicker needle. That's again something which is debatable, and a lot of people have different concepts about that.
Yeah. I think that was discussed in the discussion when we about armamentarium. And yes, you're right. We prefer to use a thinner, longer needle
Yes.
than thicker,
Yes.
shorter needle.
Yes.
But yes, like you said, the conventional needle that we use, the syringe and that we use is a 26 gauge.
Yes. Yes.
And a 1.5 inch needle. So, speaking in those terms, can you?
So that sometimes we generally read Western literature. I mean, to quote the very famous textbook on local anesthesia, Malamed, he mentions about using 2 different gauges for intraoral anesthesia, 25 and 27. And he says use 25 long needle for mandibular, inferior alveolar nerve block. But if we look at the Indian scenario, we do not get 25 and 27. It is only 24 and 26. So, and as far as the length is concerned, our needles are much, much longer. A long needle which is mentioned in the Western literature is 32, while long needle in Indian context is 38. So, when Malamed says 3/4 of the needle has to go within the tissues, it is 24 or 25, while 38 of this becomes 29, where actually we may be harming the patient. But the common mistake, more than the length of needle, the common mistake that people do is, I have seen it around, short needle being used for inferior alveolar nerve block. We will never reach where we need to reach.
Yes. So, failure to achieve anesthesia because of the wrong armamentarium that we use.
Yes.
And for a third molar surgery, do you prefer a conventional direct nerve block, inferior nerve block, or a Gauguet's technique?
Always, we're more comfortable with inferior alveolar, the conventional, the direct technique, inferior alveolar nerve block. If it fails, only then I would consider the other techniques. Yeah. For the simple reason that the vital structures around are lesser as compared to the other Gauguet's.
Yeah, that's a point well taken. In case if the conventional inferior alveolar nerve block fails once, maybe twice, due to anatomical variations which we do not see clinically, you go for the Gauguet's. That is how I practice as well. And I also take one more thing into consideration, the apprehension of the patient.
True.
If the patient is apprehensive, then straight away I prefer a Gauguet's technique over a conventional inferior alveolar nerve block. And also, your block is working perfectly all right. Still, patient complains of pain. What could it be?
So, yeah, the classical phrase is soft tissue anesthesia that you get at the lip and the tongue is never indicative of pulpal anesthesia. Yes. It is never reflective of that. So, yes, in that case, I would think of, if my technique has been correct, I would think of the accessory innovation. So, probably try to address.
No, I'm not talking about the pulpal anesthesia. Doing an extraction. Patient complains of pain. Your lingual nerve, your long buccal nerve, and your inferior nerve block is perfect. But still, patient complains of pain. There is no localized infection.
Absence of pulpitis. That's a very tricky scenario. Absence of pulpitis also.
Nerve to myloid is one thing.
That's the accessory. Yes. That's what I meant by accessory innovation.
Okay.
So, nerve to mylohyoid, that is one. Also, the branches from superficial cervical plexus.
So, yeah.
That is the thing.
When there is a little bit of this thing that I would want to add on to. When we are looking at IAN, we are already much more proximal to the
Yes.
site at which we are working. So, if you're looking at an impaction, often the reason for impaction is pericoronitis and than any
True,
other
true.
infection, and they have this issues of trismus. So when this issue of trismus is there, Gaugates becomes a slightly trickier nerve block to give than an IANB.
Because you need good
for
mouth opening.
yes, good mouth opening, and reaching the neck of the condyle becomes the
It's
key.
just not
So
possible.
until and unless you are really experienced in giving a Gaugates, I would not want any a fresher to start trying a Gaugates in a patient when they have pericoronitis, because I think that the failure rates for Gaugates are actually more compared to a conventional INB.
Spoken like a maxillofacial surgeon.
No, I spoke about my limited
that-
experience of 30 years.
No, so that's why I said for an experienced surgeon, definitely Gaugates will work. But if I am asked to give a Gaugates, I would rather repeat an INB than go ahead for a Gaugates, because getting that neck of the condyle and not having a complication of facial nerve palsy is another thing that I'm really worried about, because when that happens, the patient literally loses his confidence
Yes,
in you,
yes,
and then
absolutely.
handling the patient for an impaction becomes difficult. So I would really think
Sir,
on these lines when I'm trying to go for a Gaugates.
Sir, actually, to quote something very interesting mentioned in Malabar, he says that most of us do not have the patience to wait for the block to act. We think that we've not given the right block, so hurriedly we give the other block. While when the patient is actually showing signs of good anesthesia, it would actually be the first block which is working.
Exactly. So
Yes.
that's a very, very important
We don't
point.
wait.
Yeah. For a infiltration, textbook says 2 to 5 minutes. Why can't we wait for 5 minutes? Why
Exactly.
wait only for 2 minutes before you start working?
So sometimes
And-
it is more than 15 minutes, it
Yeah,
seems.
yeah. You need to
Statistical.
wait.
Yes,
Yeah,
yes,
you
we
need to
need to wait.
That brings to another point that I would like to quote here, is that when you are operating in general anesthesia, we start off giving LA,
Yes.
even if we operate
yes,
a patient,
yes.
but then we don't wait before we make an incision. We start seeing blood all around, because the reason why we give local anesthesia is for basically for vasoconstriction, but then we don't follow that principle. Again, patience,
We don't
yes,
wait.
yes.
patience
We don't
is
wait.
the key.
He just
to
cannot
make-
respond,
Exactly.
but he is undergoing the pain.
Exactly.
Yes.
So the thing is, it is comfortable for both parties, both the doctor as well as the
and
Patient.
the anesthetist
Yeah.
in the OT
yeah.
and the
So
anesthetist. Yes.
time, I think that is a very important. Like what you're absolutely right. Sometimes the first block may be working, not the second
Not
one.
the second block.
Maybe that may be a
I
incorrect.
mean, it's a very important take-home message for the trainees. You need to wait.
And speaking about the mandibular nerve techniques, we have in literature about the what do you call the curved needle pen needle technique.
Infamous.
Yes, and so what is your take? Because it is published.
It is
Published in the literature. So what is your take on that, and indications, contraindications, or is it indicated at all? Can we achieve the same result with our conventional inferior alveolar nerve block?
I wouldn't prefer bending the
Okay.
needle. Definitely, no.
I would not prefer bending the needle.
For the simple reason that
It
can
becomes
lead
It
to
weak.
becomes weak
weak.
and
It
it
becomes weak.
breaks.
okay, so ideally you don't prefer, and we don't advise as well.
We don't advise as
Yeah,
well.
yeah.
Yes.
Thank you. And what are the nerves? I think we have already discussed about the various innovation. But the another very important point that most of us miss out is the area where you check for anesthesia, and particularly so for the young the students who are doing your undergraduation. Subjective, objective, yes, what the patient says and what you elicit. Where do you check for anesthesia for the inferior alveolar nerve?
The first, subjective. Numbness, whatever the patient feels because of the terminal nerve branches. We go by the typical, the mental nerve, the lower lip, and the lower lip, gingiva, and the lingual nerve. So you go towards the tongue, check for numbness. Apart from that, the buccal mucoperiosteum after you've given the long buccal nerve.
If we have to check for the site of anesthesia, I think canine or distal to canine between the first premolar
mental
and the second
nerve.
molar
Mental
will
nerve.
be
Yes.
the ideal
Yeah.
site
So
to check.
where the
Bifurcation happens, nerve is out, you're not covering the long
Yes.
buccal is not involved, and if that area is numb, then we
so
can proceed.
and also another important point is that just one poke, that is enough,
That is
rather
all.
than playing all over the place and traumatizing that area. So that is another important point to note, that between the roots of the premolars, that's where you check for anesthesia for
Yes.
the inferior
And
alveolar nerve.
No.
So long buccal nerve is the soft tissue distal to the first molar, whereas lingual nerve is the lingual soft tissue. Don't prick over the tongue, is the lingual soft tissue.
yes.
But this is very, very important, and you will know when the patient says, your block is not
The
working.
common mistake is if somebody is removing a 7, they would check the buccal mucoperiosteum adjacent to the 7. That is a common mistake.
Yes.
You always come forward, check between the
Yeah,
premolars,
yes,
because
yes.
that is where you have the terminal nerve endings.
Yes, yes. So
But having said that,
coming to that, we do surgical removal of the impacted third molars, and when we have to section the tooth and remove, your block works perfectly
yes,
all right.
yes.
And then they
And
complain of sensitivity.
section, patient complains of pain.
Very common.
Yes,
Very common.
yes. So your
The first instinct is to give an intrapulpal, intraligamental, all possible. Yes, intrapulpal. Yes.
yeah,
we would.
intrapulpal drop and with a
Lot of force. Yes.
pressure, compress, close the crown, section crown with a cotton or gauze. And
So that's a very
injection.
important point that you
Yeah.
have raised. So when you give intrapulpal, it is not just the chemical action of the local anesthetic solution. It is also the pressure. So that is a very important
Yeah,
thing.
and-
This again, you all must follow this. Adequate pressure while injecting, as well as holding on the solution into that area for some time. Very
Yes,
important.
yes, and it works wonders. Immediately the patient will be comfortable and you are comfortable,
Yes.
and the
Yes.
tooth can be removed in no time.
Absolutely.
Yeah. So
Even after that, if it does not become numb, which also happens quite often.
yeah,
So yes, I generally think of the accessory innovation. Give one on the lingual side, intraoral for the intraoral mylohyoid nerve block.
another very important clinical tip is that giving a intraligamental,
Yes.
that works wonders.
Yes, it
Again,
does.
pressure.
Pressure.
You can see the blanching
That's the key.
of the tissue, and you don't have to wait for minutes here.
Instantaneous. It is.
Instantaneous. And likewise, maxilla and mandible, it works the same. Even though the quality of bone in mandible is dense, cartical bone, but still it is a instant result that you can see following a ligamental injection. So the supplementary injections are
Quite often we come across this scenario also. There will be, like what you mentioned in the regarding the earlier lecture, when there is pericoronitis surrounding the tooth and there is infection of different grades, mild or moderate. Severe we wouldn't address, but mild or moderate is a tricky one. The patient wants to get the tooth removed. but your LA is not working. So those are very tricky scenarios. Achieving anesthesia, I mean, what would you generally consider?
Block should work, ma'am. If the block is not working and it is related to the pH issues because we have a pterygomandibular space infection that is involved, then we can probably look at alkalizing the LA so that we have better profoundness of anesthesia.
That's a very effective technique. But would you start the patient with a course of antibiotics or something?
Definitely.
Would you be? I think that is something which is so understated.
Yes, instead of going in for acute infection and then
course.
doing it immediately, probably one course of antibiotics which will control the infection.
Also anti-inflammatory, which will reduce the inflammation, which is also changing the pH.
Yeah, you're absolutely right. But then, what's the best form of relieving pain relief? Remove the cause.
Remove the cause.
Yes, I do agree. When you start the patient with antibiotics, if the patient has got space infection or kind of a dentallular abscess, but then again, I may tickle. Yeah, I may.
Yes.
But then that is how I was taught.
Yes.
Treat the cause. Patient comes with acute pain.
Remove the focus of infection.
Focus of infection. Patient goes back happy.
Yes.
Again, give a no block. It works. And then, if required, give a supplemental injection. And when there is an infection, the tooth will be invariably
slightly mobile.
If it is mobile. Yes.
So I think
there is bone loss and
yes. So invariably, I'm not saying 100% of the time that can happen, but then that is how.
And I think that is where we have to look at what sir mentioned as to go in for a Gaugates instead of going for a conventional inferior or go for an extraoral technique.
Because sometimes patients are like what you said, they are particular.
Yes.
They want to get it removed.
They want it to be removed. Yes.
And start off with antibiotics, or in case if it is an uncontrollable injection, yes, definitely start off with empirical antibiotics.
Yes.
And then wait for a couple of days, 3 days. Wait for the infection to first to drain.
Yes.
And then you go ahead. Again, not only this aspect, again, the comorbidities also have to be taken into consideration before all these aspects. Yeah.
So there is a theory that when you have irreversible pulpitis, the best thing would be to get it removed, the focus of infection, like what you mentioned. But when there is irreversible pulpitis, sometimes there are some changes which happen to the sodium channels. You apparently have overexpression of a specific type of sodium receptors called tetrodotoxin resistant receptors, which are not amenable to the local anesthetic injection. So that is where, and also this theory of chemical central sensitization. We will never be able to fight these two with our normal local anesthetic solution. So these are the few clinical scenarios where one may consider starting a course of antibiotics and anti-inflammatory. And in fact, some go on to say that we can use even steroids, a dose of steroids, which will bring this infection down. I mean, which can potentiate the action of local anesthetic solution.
So that use of steroid is a double-edged sword. Whether we want to use it or we don't want to use it.
Yeah. In fact, sir, this is very interesting. When you administer LA also, like alkalinizing, you give, it's called the twin mix.
Twin mix.
Local anesthetic solution plus steroids. Administer, that's supposed to potentiate the action of local anesthetic solution.
It increases the duration of action and also it reduces the inflammation post-operatively.
Yeah, that is... So post-op for surgeons, yes, we do prefer
minimal edema, minimal pain.
And so I think we have covered almost all the topics regarding the mandibular nerve techniques, mandibular injection techniques as well. So now
probably the variation as far as pediatric population is concerned, we go a little lower. As far as block is concerned.
So following the discussion, we'll have the demonstration of various techniques. So thank you both so much for this fantastic
discussion.
Thank you.
Thank you, sir.